Hi, Joe. I'm Molly, the student nurse. Can I have you state your name and date of birth?
Joe Van Buskirk, April 14th, 1980.
Great. All right. So, Joe, today we're going to be doing a cardiac assessment. Sounds scary. It is not. So what it involves, I'm going to ask you some questions, and then I'm going to inspect, palpate, lightly touch, and then listen to heart sounds. Sound good?
Yep.
Okay. So before we get started, I'm going to ask you some questions. Do you have any history of heart disease, things like high blood pressure, AFib, heart attack, heart failure, stroke?
No.
Any immediate family members have that history?
No.
Okay. Do you have any sleep apnea?
Nope.
Okay. Any signs or symptoms right now or in the past of things like excessive sweating, chest pain, shortness of breath with things that there shouldn't be shortness of breath, like just walking around your home?
Nope.
Any edema, so swelling by the ankles?
Nope.
Any palpitations, so feeling like your heart's going to jump out of your chest?
Nope.
And then any orthopnea, which means changing your body position to breathe better. Usually at night, people may put pillows behind them, breathe better, anything like that.
Nope.
Great. And then, Joe, what do you do for a living?
I work at Johnsonville in the office.
And then do you move around a lot at work? Are you more sedentary?
About 50-50.
So you do walk around at work?
Yep.
Okay. And what's some typical foods you eat in a day?
I try to eat protein bars and fiber bars.
Good. All right. And then are you a nicotine user?
Nope.
What about alcohol?
On the weekends sometimes.
Okay. And then have you had any big weight fluctuations in your life before?
Nope.
All right. Any cardiac meds, so things for high blood pressure, high cholesterol?
Nope.
Any diuretics or water pills?
Nope.
What about aspirin on a daily basis?
No.
Oh, great. All right. So I'm going to inspect here. So let's identify the base of the heart. So I'm going to find the angle of Louis and scoot over to the right here and left. So this will be our base of the heart. And from the second here, I go third, fourth, fifth, to the left a little, mid-clavicular line. This will be the apex of the heart. It's where the mitral valve is, also where we take the apical pulse. And this will be the PMI, or point of maximal impulse, where the heart contracts the most. You'll feel it the most, or hear it the most. All right. So I'm feeling for any thrills, which is vibrations felt from turbulence. That can happen with murmurs, sometimes from the murmur, then from aortic from stenosis. So the valves in your heart, you have 4 valves. They act like a door. They should be fully opening, fully closing. So when they don't fully close, you can have regurgitation. The blood will flow backward. And we would hear that. Or we can hear murmurs where the blood flow doesn't fully shoot out. So we have less cardiac output. And we would grade murmurs for where they're located, the intensity, how loud they are. The loudest is 6. Things like that. So I'm going to be listening for all of that. I'm also going to listen for pericardial friction rub. That sounds like 2 balloons rubbing on each other. It's felt at the PMI, so we'll do that in a minute here. I'll have you lean forward and I'll listen upon expiration. I also meant when I was feeling to feel for any lifts or heaves. Okay, you don't feel that, and that could be a sign of hypertrophy. Meaning the heart, the ventricle is larger, the heart muscle is larger. So I don't feel anything like that. Okay, so let's go ahead and listen. Before I listen, I'm going to mention what I will be listening for. So we listen for our normal heart sounds, or S1 and S2. S1 we call the love. It is best heard at, again, that mitral valve area. S1 is the tricuspid and mitral valve closing. It is at the start of systole. S2 is a dub sound, we call it dub. S2 is the start of diastole. It is heard best at the pulmonic valve, which was our second intercostal space to the left of the angle of Louis. And that is the aortic and pulmonic valves closing. Abnormal sounds would be S3, called the gallop. For those under 40 or children, it's usually benign. Once you're older though, it could be a sign of heart failure. It is heard immediately after S2. S4 is heard immediately before S1. S4 could be a sign of ventricular hypertrophy, uncontrolled hypertension, or aortic stenosis. So all things, if we heard, we would document and make sure it's followed up on so we can get to the root cause of it. So then I'm going to go ahead, I'm going to listen to 5 spots, and I'll list them when I get to them here in a sec. So we're going to start with the diaphragm, listening with the diaphragm, lower pitch sounds heard. So we're going to find the angle of Louis, and we're first going to go to the right. This is the aortic valve. Okay. Over second intercostal space on the left is our pulmonic valve. Go down to the third intercostal space, Erb's point. Then the fourth intercostal space is a tricuspid valve. And the fifth, and then we go a little bit mid-clavicular, middle of the clavicle. This is, again, like I said earlier, the point of maximal impulse, apical pulse, and then where the mitral valve is. Okay, so to listen for pericardial friction rub, I'm going to have you lean forward and breathe out. Okay, I did not hear it. So then, sounds like S3 are heard best with the bell of the stethoscope. So we're going to go ahead and listen with the bell. Okay, great. Heart rate is a little fast, but you said you had coffee earlier? Okay.
Yep.
All right, and then with the diaphragmless stethoscope, I'm also going to listen again at the apical pulse, and I'm going to feel the radial pulse at the same time. If I'm hearing it and not feeling it, that could indicate a pulse deficit. Pulse deficit could be from AFib, aflutter, dysrhythmia, the rhythm's off. And we need to get to the bottom of that. So, let's go ahead, angle Louis, second. Go over a little. Good. So I did not detect a pulse deficit. So the heart pumps the blood out to the tips of your fingers, tips of your toes. So if we do want to always consider our skin temperature and color to make sure the blood's getting everywhere it needs to go. So we want it to be warm and dry, warm. And for you pinks, I don't see any lack of color or pallor. That could mean the blood's not getting to the tips of the fingers or such. Don't see that. And I'm just going to talk real quick about venous and arterial insufficiency. So with arterial insufficiency, we would see things if you were to have an ulcer be very deep, because your arteries are much deeper inside than the veins, are more superficial. That's why we feel the pulse in the veins. So with arterial, it would be deep if there were an ulcer. Skin may be shiny, lack of hair, thick nails. There may be intermittent claudication, which is pain with walking. With venous insufficiency, we may see things such as capillary refill would be slow or sluggish. So that is brisk, that is good. Blood flow is there, your hands are nice and warm. We would see, if there were to be an ulcer, it would be more close to the skin, more superficial, maybe aching and cramping in the legs if there's venous insufficiency, maybe some edema. And then I also want to talk about orthostatic orthostatic hypotension. So how do we check for that? We take a BP. I would have you lie down 5 minutes. After that 5 minutes, I would take your apical pulse and your blood pressure. Then I would have you stand up, and I would take your apical pulse and blood pressure right away after 1 minute and after 2 minutes. I would then compare all those numbers. If there were to be a drop of 20 systole, 10 diastole, or an increase of blood or heart rate by 20, pulse by 20, that could be positive for orthostatic hypotension. And then I would teach my patient safety measures so they're not a fall risk and get injured. Do you have any questions for me?
Nope.
All right, thank you.